Hello, this is Dr. Gomez from Bethesda Pediatrics of Queen Creek, doing business as Main Street Pediatric, and this is our TI2 and we are going to go over all the elements of our project from our charter to our process map, our root cause analysis, and PDSA cycle. During our project, our major goal was to close the loop in health-related social needs, a gap analysis of our social determinants of health, in delivery and execution of care delivery. And our four major components in this project was to establish a problem, look at a desired outcome, the benefits of these, and the tasks that had been done. The problem is that even though there are many community resources available to meet patients' needs, there are barriers to overcome, and those unmet health-related social needs like food, housing, financial instability, mental and physical abuse, etc., that are faced in our communities have a heavy adverse effect on patients' health. The desired outcomes of these projects was to map processes for delivery of screening of these HRSNs and refer and deliver resources in an efficient and timely manner. Identify major barriers for our patients to acquire those services and identify one screening form to be acceptable for all of our ACOs and insurance companies. Also utilize technology and community resources to meet the need and educate patients on the importance of SDOH and how important it is to acquire those services, and closing the loop, reporting that services were received and that there was a positive impact. The benefit of this, of course, is to intervene and break a negative healthcare cycle and guide a patient to health services they need so they can have healthier lives. And the different tasks that were done in order to produce this were gather resources, create those process maps, identify any barriers, communicating with ACOs and the importance of one universal screening tool, identifying the best practices, and availability of services. So we started with our map processing, and the initial step was making sure that our patients will receive their screening. And as what how we did it is that we plan to do it is like through once patient arrive, and the front office will give that screening tool, and then the patient will either accept or decline it. We did find out that there's a lot of patients that actually do not want to be asked about those questions. But if they will accept it, then the front office will identify any positive and take back to the provider so the provider could code it accordingly, and then the provider will give it to our care coordination team. And the next step on that process was that the care coordination team will receive the positive screenings and will look at the different need, either childcare, employment, healthcare accessibility, family and life stress, transportation, or behavioral health being the ones identified to be the most commonly requested help with, and then the care coordination team, choose where to refer, either to unite.com or through different ACOs and their insurances, or to work them internally in our clinic and then send the referral to the appropriate resource. Then, once the referral was received, our team will call the patients and leave voicemails and keep attempting, and eventually, hopefully, in some cases, able finally to reach them and ask if they had received that information, and if once it received, is there anything else? Was it to get feedback? Was it useful? And then that way close our loop. So we came to see that this was not achieved and as we were expecting. So we try to do a root cause analysis about the reasons why this was not achieved. The main problem being that most of the time patients did not receive those resources that they had been identified as a need. And the team that was involved was everyone from front office to medical assistants to the provider to our care coordination to ACO teams. And to do our root cause analysis, we use a mixture of the five whys and the fishbone diagram. And we collected data from our screening tools and kept track of everything and following up on reports to see if there was any negative patient interaction or engagement. So we asked ourselves, why were they not receiving these resources? And the biggest one is the lack of communication. Uh, there was also the fact that we will send why was the lack of communication? Because we will send referrals to the ACOs that have care coordinations that are supposed to be helping, and these ACOs uh, would not do any follow-up. And the reason behind it was because they kept leaving voicemails unanswered by patients. And the reason is because actually the patient is not engaged and they really do not, they refuse to receive any help. They just did not want it to be part of that process. So why was the ACO not follow up? The lack of manpower, maybe the lack of resources, or not being able to communicate with the patients, leaving a lot of voicemails. But then also patients just reporting they no longer needed that help, and patient, or many times that patient just has no insurance anymore, so then the ACO will stop helping. But our team will intervene. Now, patients were contacted many times 3 to 6 weeks later. So we're trying to figure out the causes of that. And we find out that there's a lot of training involved in the staff members, and that is a big, uh, a time-consuming effort. And then there's the list of patients to be followed up becomes extremely big, and staff is constantly turning over or they're on leave. And also we found out the other biggest barriers were incorrect phone numbers for the patients because they change their phone numbers too frequently or because the patients are moving, they're constantly moving. And all these leads to just a delay in being able to communicate. Also, many times they just wouldn't receive these social needs. Why? Because the staff was not able to talk to them and constantly leaving voicemails, or we will fax the screenings to the ACOs, but then they wouldn't follow up. And then if the patient was reached, many times they just would say that they no longer need any help. And many new staff also not following the procedures that we had established, or community resources not reporting back to us, or and again insufficient manpower to be able to follow up and call. Um, so our PDCA cycle altogether, we planned and implemented, and then study what we have um, accumulated information we have accumulated from all those positive screens, and then we keep acting and moving and creating new plans. So in our plan, and what we did was we made sure to deliver all those screenings and we scanned them to all those patients' charts, and every positive one we give to our lead care coordination team, and then they will communicate with ACOs, and if not, we will handle them in-house, and then we would do a tracking of all those positive screenings. In order to do that, we would do a internally sharing an Excel workbook, and that team will evaluate ongoing processes, learn what was being successful, what not, making changes to improve our processes and adjust them accordingly, and see what was working and what's not. And during our do and study part of everything, we definitely recorded any activities, observations, in anything new. We definitely, that's when, as we were doing and studying, we saw that the lack of communication with patients, with them not answering and not returning phone calls. And then even when finally being reached, those resources were not just being fast enough given, and those positive screenings uh, sent to ACOs, ACOs not reaching out to patients on a timely manner, uh, or then just not calling us back. So again, needs not being. So we did study the different sections, needs, and try to identify where we needed to create more resources. And we looked into how to improve communication with the patient and making sure that we needed to try to do as much as possible before they leave the office. And that's the hardest obstacle. They're rushing, their kids are crying, they need to leave. It's just once they're out, is they don't answer their phones and they rarely call back. But also, very interestingly, we found this social aspect where many times they just don't want any follow up. They state once we call them and they do answer that they didn't mean to say yes to any of the questions, despite clearly stating that the yes were struggling and yes they needed help. So we're thinking that they just probably don't feel comfortable receiving help. We ask and they just say no, we just don't know, need it. We wonder if there's a cultural, social reasoning behind it. Again, it's that lack of communication to try to figure out why are they no longer interested in receiving resources when they had initially stated that they were struggling in that specific area. And in our act, part of everything, what we're doing is try to come with ideas on how to change and implement those changes, making sure that the patients don't leave without first signing a consent. For unitedus.com is one. Another huge one that we believe is making an impact is that we are communicating with the patients the importance of the screening for them to understand that we are doing it with no other intentions than to help them, and just educating them on how important it is for their physical health to be okay, to also have all those other health related needs, social determinants of health to also be fulfilled, and also tell them that they will be expecting phone calls and voicemails and emails from us and the whole team trying to just get to them, not to ignore those phone calls and voicemails and emails. We also ask the ACOs a better way to communicate with them, how for them not to take as long to actually get to talk to the patients, but then to follow up with us and let us know any missed opportunities on how to help our patients. And then we also encourage patients to follow up with their insurance and with the community resources. Overall, the biggest goal is to find ways to let our patients be able to obtain resources. And our new challenge is trying to identify how we can truly engage them and try to identify the reason behind them not wanting help after they had initially said they wanted to. It's a multifactorial component, and we keep tracking and following up, and we continue to leave voicemails, but we're also acting in identifying those patients to capture them when they come in person to the next visit. Here are your resources from last time that you mentioned for you to achieve, and trying to get them engaged into letting us know what would be a better way to get um, those resources to them. Thank you for your time.